here's the muscles of the rotator cuff right here. This view right here, as in the last slide, is the patient facing you. So it's the right shoulder. The rib cage has been removed, okay? So this muscle subscapularis right here sits in between the shoulder blade and your rib cage. It's the muscle that's responsible for internal rotation of the shoulder. This muscle here is, the majority of it's actually on the posterior side, which you can see here, along with another posterior muscle here. This is infraspinatus and teres minor. These two together are responsible for external rotation of the shoulder. You can see supraspinatus sits up in here. It actually goes underneath this little knot that you feel right here, which is what's called the acromioclavicular joint. It's the joint where the clavicle here comes together with the shoulder blade. This muscle belly sits in here, and the tendon actually goes underneath that AC joint and takes its insertion here on the head of the humerus or the arm bone, as well as these two other muscles here on the back side and subscapularis here on the front side. So that's kind of an overview of the rotator cuff complex there. This shot here is an indication of a rotator cuff tear, specifically the muscle. The muscle underneath the AC joint there, that supraspinatus muscle, is one of the muscles that's quite involved, usually with shoulder problems. We see a lot of supraspinatus tears. We see a few infraspinatus and teres minor tears on the posterior side. We see them every once in a while, but not quite as often a subscapularis tear. So one of the other things that I want to point out is the long head of the biceps goes in here, and like I said, it will take its insertion up here on the labrum that's inside the joint right there. The other thing I want to look at, and this is not really clearly defined here, but you kind of get the idea, that there's a connective tissue capsule around that joint, okay? And that'll become an issue with some of the diseases, or not diseases, but some of the injuries that we look at. I like this picture here because what they've done is they've actually taken the humerus and kind of just distracted it out of the joint right here. You can see this structure here on the shoulder blade. It's called the glenoid. That's actually the cup that this head of the humerus actually sits in. This right here, this structure around the rim of the joint right there, that is the labrum. Okay, the labrum is a cartilaginous material that acts to somewhat deepen that cup and help to maintain the integrity of that joint. Even though it's so loose, it tries to kind of deepen that cup to keep that joint a little bit more solid. Here you can see the long head of the biceps comes up, and that's where it actually takes its insertion, is on the top of the labrum right there. Okay? The short head of the biceps will come up and take its insertion right here on the coracoid process of the scapula. This will come back in a couple of the different injuries and things that we see that we'll be talking about. So here are some of the injuries that we see in the clinic. First one is adhesive capsulitis or frozen shoulder. I'm sure a lot of people have heard frozen shoulder before. What that is going back to that one slide where I talked about the connective tissue capsule, okay? Adhesive capsulitis is a problem with that capsule, where the capsule might be thickened in spots, it can be torn in spots. The adhesive capsulitis patient or frozen shoulder patient will actually present in the clinic with certain limitations of motion, okay? You'll come in, we'll look at active range of motion, we'll go through all these assessment things that I do, and the patient will come in with an adhesive capsulitis. They'll come in limited in external rotation. That one will be most limited in that direction, followed by abduction out to the side, followed by medial rotation. Okay, so if the patient presents kind of in that capsular limitation, then more often than not, it's a capsular issue. Okay. The next one is rotator cuff tears. You can have a complete tear where the tendon is completely gone. You can have partial tears. Oftentimes with partial tears, the patient will see the orthopedic surgeon, and the orthopedic surgeon will say, well, let's give this a shot. Let's go to PT and see if they can handle that. Sometimes they will heal themselves, depending on the extent of the tear. Complete tears, they become a problem in a spot I'll show you here. When you get a complete tear of supraspinatus right here, what happens sometimes, if the tear is fairly old, you'll have the tendon torn, you've got a fragment out here on the distal end, the muscle belly will actually try to retract, okay? And the problem with that is, especially on old tears, is the surgeon's got to go in there and try to find that, pull it back out, and suitably anchor it out there. So sometimes that's kind of a problem, getting that tissue to become able to be re-anchored down on the humeral head. The next one is biceps tendon tears. Go back a couple of slides, we'll talk about that. So bicep tendon tears, you can see here that if there's a problem with the shoulder in terms of an injury, especially trauma or something like that, the possibility exists that you're going to ding this tendon somehow, okay? You can have biceps tendon tears that are proximal, that are up here, okay? Then you can have bicep tendon tears that are distal, down here, almost at the insertion, down at the elbow. Sometimes people will lift something and they'll try to really flex their arm with a heavy weight or something. All of a sudden it snaps, and next thing you know, the patient looks down and there's a big lump up here. And there's nothing much right here, but there's a big lump. And what happens sometimes is that bicep tendon torn down here will just roll up like a window shade. And a lot of times they won't be able to tack that back down, and the patient just lives with it. You can functionally exist with a torn biceps muscle. It doesn't look too pretty, but you can live with it. The next one is impingement syndromes. Primary impingement syndrome is a problem with supraspinatus, that one tendon that we just looked at. Let's go back to that. It's a problem with this tendon here as it relates to this joint sometimes up here. Sometimes as we age, you start getting bone spurs and roughenings underneath here and everything. That combined oftentimes with a weak rotator cuff complex there, where the rotator cuff is weak enough to where it's not keeping this humeral head seated in that joint. With overhead activity, this bone will try to migrate superiorly there. Now the problem is, when that bone starts going north like that, this tendon can run the possibility of being torn, or frayed from these bone spurs and roughenings underneath here. Oftentimes, surgeons will go in when they're doing a rotator cuff repair, and they'll do something called a subacromial decompression, where when they're in there with the scope, they'll take a little grinder and they'll go to the underside of the AC joint here and they'll polish it. They'll get rid of all the spurs and everything, clean all that up. The next type of impingement syndrome is a secondary impingement. And a secondary impingement starts to relate to more of a trauma type situation, subluxations and dislocations, which we'll talk about in a minute. There's much more laxity and problems that way with this joint, as opposed to having a problem directly with the supraspinatus tendon, or one of the cuff tendons. The next one is an MDI patient, or a multidirectional instability patient. These are usually trauma cases. Falls, motor vehicle accidents. I have a very nifty, anybody wants to see it, on my phone. I've got a patient that I worked with a while back that was a professional mountain bike racer. And he's charging down this hill, and his buddy's behind him with a GoPro filming the whole thing. Well, the guy crashes at the bottom, and he stands up, and this arm is just dangling, and he's screaming to high heaven because it's not too pleasant. So You get him in the clinic, he is lax in all kinds of different directions, from the trauma. I mean, he's torn tendons, he's torn ligaments, and now with a multidirectional instability patient, they can be lax inferiorly, they can be lax anteriorly, sometimes posteriorly. So they're a mess, and this thing's going all over the place. And the deal with subluxation and dislocation, first of all, dislocation is when the humeral head comes out of the joint, okay? A subluxation is a minor dislocation, where it doesn't quite come out of the joint, but you really probably, at best, you've stretched and possibly torn some of the ligaments in there. So there's a couple of different types of dislocation. And the one that we see most often is called an antero-inferior dislocation, where the humeral head goes that way. So it comes from here and it goes out that way, okay? The patient will come up and this arm is dangling, and they can't control it, and they're in a lot of pain. Not as common, but we see every once in a while posterior dislocations. I think there's a couple of YouTube videos on posterior dislocation. I think there's a football player. He dislocates posteriorly, and he's fighting to keep his arm up in the air as he's running off the sideline screaming, okay? So that's subluxation and dislocation. Slap lesions, labral tears. So let's go back to this shot here. There again, here's the labrum, okay? And every once in a while, through whatever trauma or different problems, you can tear this labrum. A slap lesion is a lesion or a tear of the superior margin up here, anteriorly, posteriorly, in the labrum, okay? And a lot of times, or not a lot of times, but sometimes you've got also involvement of that long head biceps tendon because of a slap lesion or a tear of the labrum. Let's talk about total and reverse total shoulder replacements. These are fairly new, and a total shoulder replacement, let's go back, is really kind of interesting. What they do is almost like the hip. They're actually very close to what they do with the hip. They will come up and lop the humeral head off, and they'll put a titanium prosthesis on there. Then what they'll do is they'll come and remove the glenoid or part of the glenoid and replace it with, it's usually some sort of a composite, okay? Believe it or not, those total shoulder replacements do very, very well in the clinic. I mean, if I was to have a total shoulder replacement versus a cuff repair, the shoulder replacements do really, really well. Another procedure that they do is they do a reverse total. What they do with that is they'll take the humeral head, they'll put the cup here, they'll take the glenoid, replace it with the ball. So you've got the ball here, the cup here, reverse of what you normally have. They do very, very well along with the total shoulder replacements. I have a total shoulder in Tustin right now. She's probably a month post-surgical. She has very, very little pain. She has great motion. You have to progress them pretty carefully, obviously, but I mean, they come out of the OR doing very, very well. Posture. Your mother was right. A couple things here, and posture has a huge bearing on shoulders. If I'm like this all the time, the humeral head has a tendency to want to go forward. Okay, now you're starting to get into that posterior capsule problem. You're going to come into the clinic. You're going to be in pain. You're going to be lacking internal rotation of the shoulder, and a lot of the times, we really, really try to enforce posture in the clinic. We just harp on it all the time. Forward head position. Forward head position is when you're, it's like the 14-year-old slumped over like that. The human head weighs on average between about 8 and 10 pounds, okay? For every inch that you go forward, that weight doubles. So if you are 1 inch anteriorly, now you're lugging around 20 pounds. 2 inches forward, you're 40 pounds. Go and pick up a 40-pound dumbbell in the gym sometime. It's a lot of weight. It's a lot of force on the neck and upper thoracic spine. In my workup, looking at active range of motion, we'll be going through that process here in a minute. I look at what's called a resting humeral position. So I'm watching the patient as they come into the clinic. I'm watching them in the when they're checking in the lobby there. I watch their posture. I watch how they stand. I watch how they sit before I've even seen them. And boy, if they come in with a sore shoulder and there's a lot of this going on, I'm already heading down the road of a primary impingement syndrome, because I'm already thinking that posterior capsule's tight. You're immediately rotated on your scapula back there, and you're probably lacking internal rotation. And so, I mean, posture starts me down a road before I've even talked to the patient. Position of the scapula. So when I do a workup first, everything I do initially with shoulders is based on posture. I want to look at your posture. I'm going to look at you from the front, I'm going to look at you from the side, and I'm going to look at you from behind you. The position of the scapula, we see all kinds of interesting things. Normally, it's quite flat against the rib cage. It's in a certain position. We will see things like what we call medially rotated, where the shoulder blade is kind of twisted or rotated a little bit, and you get a good view of that when you look at the patient from the side. When I look at a patient from the side and I see a little bit of a protuberance there at the shoulder blade, they're medially rotated. Now I'm really going down the primary impingement road. The other resting humeral position of the scapula that we see is something called anteriorly tipped, where if you see, I can't get back there, but the very bottom of the shoulder blade down there, sometimes it's kind of protruding a little bit, okay? And that means that scapula is anteriorly tipped. That's often due to a small muscle in here called pec minor. If that muscle is tight, it will try to take and pull that scapula forward. So the patient will, in its resting position there, will have a little bit of a protrusion down at the very bottom at the inferior angle of the scapula there. We'll see another situation called winging, where the inside part closest to your spine of the shoulder blade is cranked out like that, where you will see a definite medial border being exposed there. Okay, that's called winging of the scapula. That's due to another muscle underneath here, boxers. Okay, you look at boxers and they have these 3 little fingers right here. That's a muscle called serratus anterior. That's what keeps this shoulder blade onto your rib cage. So if that muscle's weak, or there's been some sort of a neurological problem with that muscle, you're going to have that shoulder blade in that winging position. Clavicular angle. That's the angle of your clavicle right here. It's one of the things I look at. It's quite common in the clinic for physical therapists to want to always stretch the upper traps here. And you go in there for neck problems, everybody wants to stretch that upper trap. What we look at is we look at this clavicular angle. Okay? It should be, normal is about 10 to 15 degrees up from the horizontal there. The upper trapezius here comes and takes its insertion on the outer third of the shoulder blade, the clavicle there. So if that musculature there is tight, he tries to pull it north. So I will see patients that maybe have a 25, or in extreme cases, maybe a 30-degree clavicular angle. Now that's the patient that you want to stretch that upper trap a little bit, but I don't stretch muscle that's a normal length. So if somebody comes in and presents with a 10 or a 15-degree clavicular angle, we're not stretching upper trapezius. Okay? Let's talk just briefly about pain. I'm going to skip referred pain for a second. I'm going to go down one. Type 1 pain or nociception. That's kind of the pain you feel if you've had an initial trauma or initial, say like fracture pain. It's that initial trauma, the pain is bad, and that's what's referred to as type 1 or nociception. Type 2 pain is say you've had some kind of an injury, it's starting to kind of heal a little bit, but boy, you're still painful. It's not quite as bad as the day that you've fractured your arm, but it's still painful. That's type 2 or algogenic pain. Type 3 is pretty serious, actually very serious. It's called maladaptive. And this is where pain starts to overrule your whole life, okay? Everything in your daily activity and pretty much everything in your thoughts is just completely guided by pain, okay? Referred pain. Very common in shoulder injuries to have pain in the shoulder, and then as we go through therapy, the patient will come in and say, we'll ask him, so how's the pain? Well, it doesn't really hurt too much in my shoulder, but it is killing me down here in my bicep, or it's killing me up here in my neck. Okay, that's referred pain. The damage is still can be somewhere distal to where you're feeling the pain, but it's a referred pain pattern, and it's very common with the shoulder for people to feel pain down here in the biceps, triceps, even down into the elbow, and sometimes even beyond. Okay, and then as well, sometimes up into the neck. So when I do an assessment of the shoulder, when the patient comes in, like I said, the first thing I look at is posture. I look at posture, having them face me, to the side, and to the back, and I assess, everything that we've discussed so far. Then I will take them and I will have them sit down on the table, and I will come behind them, and I'm going to put my hands on their shoulder blade, and I'm going to have them go into active range, which means I'm going to have them just go up into flexion, slowly, and come back down. And what I'm doing is I'm going to follow what happens with that shoulder blade. Under normal circumstances, I want to see that shoulder blade, I want to see it elevated. It elevates, then it externally rotates, internally rotates, and depresses and comes back down as the patient's arm comes down. Okay, that's normal scapular motion. You see all kinds of interesting things. We'll see something called scapular dyskinesia. Scapular dyskinesia is where there is a problem with that normal scapular motion. Oftentimes the patient will elevate, they'll rotate, maybe they'll just go straight back into depression, or they'll go up and rotate, come down, and then as they come down further to that resting position, boy, you see that shoulder blade just like jello. It just goes, and it's really odd. It's kind of interesting. I have a patient in the clinic that has a very, very severe case of scapular dyskinesia. So I just met with him the other day for the first time, so we'll be really working with him. Passive range of motion. That's where I put you on the table and I go through very, very specific range of motion measurements, okay? I look at strength. I look at strength in the area of where the injury is, and then assess strength of the scapular stabilizers and other places too. Another thing that we look at is core strength, and I'll get more into that in a few minutes. Palpation. Palpation is where I ask you, okay, so where do you have the pain? And you'll say, well, it's right around here. And what I'm going to do is I'm going to go back to these structures here, and I'm going to be feeling around the insertion of infraspinatus, maybe the insertion of teres minor, the insertion of supraspinatus. You can't get to the insertion of subscap because it's too deep. But you just kind of feel around there and you'll ask the patient, is this tender, is this tender, is this tender? And that also gives you a clue as to what possibly might be going on. And then we have, as physical therapists, we have just an absolute ton of special orthopedic testing that we do. That helps you to sort of further possibly be able to isolate different structures that might be affected. So we do a lot of different orthopedic testing. I do quite a bit because I just like doing the testing, and it helps me to sort of differentially diagnose what I think might be going on. For instance, a very easy orthopedic test is something called a Hawkins-Kennedy test, going back to that primary impingement syndrome where this cuff tendon is sore. What you do is you just take the patient, have them internally rotate the shoulder, and they're just either sitting there or standing there. And then what I do is I take them into further internal rotation, and with my other hand, I just very lightly start to jam that joint. If that patient goes, oh, that hurts, more than likely that supraspinatus tendon, one way or the other, is pretty revved up. So there's all kinds of different testing that we do. Treatment of the shoulder. We prescribe therapeutic exercise, which may or may not include stretching, strengthening, core work, and balance. Do a lot of balance work. Let's talk about the core for a second. I know everybody has always heard, I got to work on my core, and I want you to think of the core as a soup can, okay? The circumference of the can is an abdominal musculature called transverse abdominis. The lid of the can is your diaphragm. The bottom of the can is the pelvic floor. That little seam that you have on the back of the can are some very, very small muscles that line the spine that actually attach one vertebral body to another. It's called multifidus. So that is what the core is. So if anybody ever asks you what's going on with your core, now you know what it is. Soft tissue mobilization. That's where we find scarring or some pathology in the tissue. We will do different types of mobilization of that tissue. We might go, knowing the anatomy, you'll get onto that tissue and you might go parallel to the fibers. Sometimes you'll go cross fiber. Retrograde. Sometimes I'll have a patient that says that maybe for whatever reason has a very swollen lower leg or something. What I do is I put them in a gravity independent position where I raise that limb, and then you do soft tissue work back towards the heart. And what it does is it gets rid of a lot of that swelling and edema in the limb. We also do joint mobilization. The joint mobilizations are graded from 1 to 5, and a grade 1 mobilization, we usually use that in the case that the joint is quite acutely painful. It's a very, very light way of moving the bone in the joint that will actually kind of gate pain. It'll actually reduce pain if you use a grade 1 sometimes. There's a specific type of nerve fiber in the shoulder joint, or in a lot of the joints, called a mechanoreceptor. And doing that grade 1 mobilization, sometimes it fires that mechanoreceptor and it actually reduces pain. Modalities. Pretty controversial right now. Ice versus heat. I'm a big fan of ice. I think out of all my patients, I use heat on absolutely zero. I don't use heat on anybody. It doesn't do what I want it to do. We know through the literature that if you want to build up intra-articular heat or heat within the joint, you do it through exercise and not the external application of a heating pad. Okay? Ultrasound versus laser. Ultrasound, we have now found that according to the latest literature, it does absolutely nothing. So I could ultrasound you with the machine on, or I could ultrasound you with the machine off. You're going to get the same benefit. Laser. There's cold laser that's been introduced lately. It's fairly new. We don't have a lot of long-term or longitudinal studies on it yet. So the initial indicators are that it might do something. We'll see maybe in sometime in the future. Electrical stimulation. It's a pain modality. Okay, I'm sure a lot of you have had electrical stim before. They put a couple of electrodes on you, turn the machine on, usually with ice. What that does is it is like I said, it's a pain modality. It reduces pain while you're on it. It doesn't heal, it doesn't cure, it doesn't do anything other than reduce pain. It works on what's called the pain gate theory. Okay, you bash your thumb with a hammer, and the first thing you do is you start rubbing it, right? You're providing a counter irritation to that original pain stimulus, and your brain says, "Oh, that doesn't hurt as bad." That's what electrical stim does for you. Taping. I use quite a few different taping protocols, and one of the ones that I like to use is what I call unloading. Sometimes the patient with a sore shoulder, they do not like that shoulder being traction. That's why a lot of, they'll put you in acute cases, they'll put you in a sling, okay? With an unloading taping protocol, what I do is I use various pieces of tape and I compress that joint. And instead of having that joint traction, when we compress the joint like that, the patient says, wow, that feels a little bit better. So, I like those. The patients like the tape jobs. It usually gives you pretty immediate relief. And then we're back to posture again. Posture, posture, posture. We can't just keep beating that enough. That concludes the talk. Yeah.
Just make sure people
Yeah.
get questions so those watching remotely can
Okay.
understand.
Very good. Yeah. Yes. Yeah. The question is diathermy kind of outdated? Yeah, absolutely. There's a lot of problems with it. People were getting burnt. A story. I had a little lady years ago that I used to, whenever anybody comes in, I will ask them, okay, so what are the aggravating factors for your shoulder? What do you do to make it, that it makes it hurt? Then we'll talk about the easing factors. Okay, so what do you do to make it feel better? A lot of times the patient will say, oh, I like ice. I get it. I like the heating pad. Right there, I kind of had a red flag. I had a little lady that came in years ago, and I asked her these questions. She said, oh, I just love my heating pad. Okay. And she said, but I think the other day I fell asleep on it, and I think that the covering might have slipped off. And right there, red flags everywhere. And I said, do you mind if I look at your back? She goes, no. She gets up, pulls up the back of her shirt. She had not a partial thickness, but a full thickness burn clear across her back, and did not even know it. One of the other nifty things about aging is that we don't quite have the sensation that we used to. So she had no idea that she had this full thickness burn across her back. So to your point, diathermy is not used. In fact, I haven't even seen it in clinics in years now. Yeah?
I have a partial tear of the tendon that we were talking about.
Uh-huh.
I think the physical therapist kind of limited what is the expectation I should have for whether I really will be able to eliminate that pain, especially when we talk about bone spurs?
Right.
And then second is what is the risk of not repairing that resume normal?
So the question is, you have a partial thickness tear? Partial thickness tear. What is the possibility of physical therapy curing it, and your ability to go back to playing golf and activity, right?
And can it do more damage later if you were talking about that muscle receding?
Right, right. And as you were saying, with the possibility of having some spurs and everything underneath there, yes, you do run the risk of, possibly doing more damage to it. Can we say that definitively? No. I mean, I can't tell you that, boy, I want you to stop playing golf forever. It really kind of comes down to what's the extent of the damage? What's the extent of the tear? Okay? And these clinical tests that we talked about, the special orthopedic testing and everything, they are just that. They are just orthopedic tests. They don't take the place of imaging or anything, okay? So at some point, the doctor might order up some sort of imaging to find out exactly what is the extent of your tear and damage. Can physical therapy help you? I would like to think so. We get partial thickness tears all the time, and a lot of times they do great. Other times, and like I said, it all goes back really to what is the extent of the tear.
Yeah, well, my experience is I tore the tendon in the right shoulder.
Mhm.
And after 1 week of therapy, the pain went away.
Is that right? Wow.
The partial tear just keeps getting aggravated.
Is that right?
I can go a couple of days without pain, and then sleep at night, it wears out.
Right. Right.
So It would've been better just leave it there.
At least your right shoulder says so. Any other questions? Oh, yeah.
I'm curious about nerve damage, how much of a overstimulation your nerves have after, say, a dislocation, and whether subsequent pain can be attributed to the nerve just being overly sensitive versus actually having another dislocation or indication of some muscle or something being injured.
Right. So the question is, can you have nerve damage by virtue of trauma to the shoulder? And the answer is there is a distinct possibility. When you go back to where this shoulder is right here, all of the nerves that innervate your upper extremity come from your neck, okay? So as the nerve roots come out of your neck here, they kind of collect right up in here, and it's a structure called the brachial plexus, okay? And the brachial plexus, if you have some extra, a trauma to this area here, you do potentially run the risk of damaging those nerves. So it's entirely possible. Traction injuries, where the limb's been pulled. Yeah, we see that gets into an injury called a brachial plexopathy and different things like that. But to answer your question, yes, it's possible.
So does it heal and then just come back, or this is decades old injury?
In terms of nerve injuries, yes. I mean, it's possible. It depends on the extent of the injury to the nerve, okay? There's three types of injuries to a nerve. There's something called a neuropraxia, where a neuropraxia is where the nerve has been either compressed or damaged in some way, but the basic structure of the nerve is still intact. Something called a axonotmesis, which is the covering or the axon on the nerve is damaged, okay? Then the most severe type of nerve injury is something called a neurotmesis, and that's where that nerve is severed. There are some cases, and these are, I don't know, this gets into a really technical area here. Nerve damage can come back. It's not definitive, and there again, like I said, it goes back to the extent of the damage to the nerve. How much damage is there to whether or not that can come back? I know that because I've had a motorcycle accident where I had some nerve damage, and I was lucky enough that it did come back. So.
In my case, my shoulder hurts a lot more at night rather than the day. And it makes no sense because I sleep on the other shoulder.
Right. Do you have pain when you're right side lying? When you're lying on your right side, you have pain in the left shoulder?
That is correct. Wakes me up about every 2 or 3 hours, and I keep telling it, look, dude, you're sleeping. I'm
Yeah,
not
right.
doing nothing. And I don't understand that dynamic.
Well, I get that question, and we talk about that in the clinic every once in a while. And sometimes what happens is when you're sideline on the opposite side, that shoulder's kind of going forward. And a lot of times the patient will say, oh, that doesn't feel so good. If I have a patient, say like a fairly recent cuff repair, I'll have them on the table and they'll be on their back, and a lot of times they don't like that. So what I've learned to do over the years is take a towel and roll it up and actually put it behind the shoulder there, bringing that shoulder slightly forward, and the patient will say, oh, that feels a little bit better.
Yeah, laying up against the pillow on the edge.
Right. So it's actually quite common, that pain at night. But if you don't mind me asking, what did you have done?
I don't know. I just woke up one day and my shoulder hurt like all get out. And you're the first professional I had a chance to talk to about it.
Where'd you get the sling?
I bought it at the pharmacy because I was trying to figure out ways to take pressure off my shoulder or alleviate the pain until I could get into a doctor, and that made a dramatic improvement.
Okay.
But I don't wear it at night.
Okay. Have you seen a physician for your shoulder?
You're the first one I've talked to.
Okay. Do you have a primary care physician?
Yes, Dr. Nicole.
Okay. Dina Cole?
Yeah, yeah, he gave me the spat lip this morning. He did a biopsy on a little student.
Has he seen your shoulder?
No, I told him I was coming here tonight. He
Okay.
said, well, then you're good, man.
Yeah, I'd be, if you would like to come in for a screening, absolutely, be glad to take a look at it. Okay? Anytime. Any other questions?